debate is sort of superfluous after what Hemant and Dr. Tulika and Pankaj have spoken, but let me put the whole thing in a different perspective. So the topic is second generation TKI as first line in every CML patient in India. And greetings from Bangalore. Bangalore is 21 degrees now. And sorry, Hemant, you're at 40. So, my opponent is Dr. Dinesh Burani. And in real life, if he and me stand next to each other, it will be like this. But in hemato-oncology, he's there and I'm down there. But I will show you some evidence and tell you how I can try to reach there. This is all very basic about CML. We have 3 phases that is well known. And this BCAD, what we look in the calendar, was heralded by the birth of this person, as you can make out. And in today's era, we talk of BC and AC in a different connotation before Corona and after Corona. In the CML era, I would like to talk about BI and AI. So what does this mean is before interferon and after interferon. So that is what we have. This is just to show you how nicely we have progressed in tackling the problem of CML over years. And you can see that many of our patients of CML have near normal life expectancy and they're doing well. So when you're treating CML, these are the goals. The first one is the earliest and deep response, cytogenetic and molecular. We have already seen from the 2020 ELN Guidelines. To have the least amount of progression to accelerated phase of blast crisis. The third one is to have the least development of mutations. Fourth one is to maintain quality of life, manageable side effects. And fifth one is cure of patients and the new concept of treatment-free remission. So I'll walk you through each one of these and give you evidences for this thing. So this is just to show you all the TKIs that we have today, and we're actually spoiled for choice. So let me take the first one, look at the cytogenetic and molecular remissions. And this is the first magic bullet, as you know, imatinib that came in. And this is the updated IRIS study data that we have. But from imatinib frontline treatment in CML chronic phase, we know that there are unmet needs with the use of imatinib, which is summarized in the slide. And almost 38% of these patients don't do very well. And many other patients have problems because of various other factors. And those essentially are the unmet needs because of the use of imatinib. And again, you've heard the importance of looking at early response. And Dr. Tulika nicely went through this ELN 2020 guidelines for you. And this IRIS data actually shows that the event-free survival at 84 months is dependent on the molecular response at 12 months. So what happens early on in the phase of the disease is reflected at 84 months and much later on. So that's an important thing that we need to remember. Not only the response, but early response is important. And this is by a paper from Dr. Jose Cortez in 2012. So we have drugs. This is data from comparing nilotinib and imatinib. And this is a 6-year follow-up data to show you how well nilotinib is doing as compared to imatinib. Similar data for dasatinib from the Decision study. And again, this is looking at MR 4.5 and showing you that this is achievable in more number of patients who are on dasatinib than imatinib. So this is actually comparing various studies of imatinib, dasatinib, and nilotinib. And again, talking about the event-free survival as long as 8 years for many of these molecules and shorter ones for the second generation TKIs. And this is one of the recent tables that I put in, which includes the data with bosutinib as well. And again, showing you that these second generation TKIs as compared to imatinib are doing much better in the various parameters that we assess our CML patients today as per the ELN 2020 guidelines. Now, why did I show you all this data? Is because early molecular response is important. And regardless of which TKI you use, early molecular response has shown that it improves EFS, PFS, and overall survival. And not just that, the future achievement of CCYR and MMR is dependent on this early EMR. If you look at the imatinib data, the response at 6 months, 87% of these patients fail to achieve early molecular response at 3 months. And you can imagine what will happen to these huge number of patients who are getting imatinib. Now, there was a study looking at switching patients from imatinib for deeper responses when you assessed at 3 months and found they were not doing well. And this is the paper of the study called LASER. And Dr. Sandeep and myself are authors on this paper. And this was a study initiated by Jose Cortes. Now, this is data to look at Ernest and Decision and the Baylor study. And this essentially summarizes that 1/3 of the patients who got imatinib failed to achieve EMR. So this is the next one, looking at second generation TKIs, which re-emphasize the importance of EMR. And as I've shown you earlier, achieving EMR is the key predictor for better long-term outcome. And you can see that these second generation TKIs are precisely doing that for you. Now, EMR is associated with higher rates of future MMR and MR 4.5. And this is data to show you essentially that. And this is putting in data of large number of patients. And the other way around, EMR failure is associated with increased risk of progression and death, is again evidence from these papers showing you that those who did not have early molecular response failed to achieve complete remission or MR 4.5, and they had worsening of the disease and ultimately death. So that is the evidence for deeper responses and why you should get it. Now, looking at least progression to accelerated phase of blast crisis, this is the study comparing nilotinib and imatinib. And as you can see, that the number of progression to accelerated or blast crisis is definitely higher in those who got imatinib as compared to nilotinib. This is from the dasatinib study. Again, you can see that patients who got into worsening of the disease or disease progression is higher with imatinib as compared to dasatinib. Now, this is again comparing all the studies to tell you that there is improved responses with second generation TKIs, but survival is still not shown, probably because this is the term of follow-up with these second generations is not long enough. And also, so many of these studies have had crossovers. So let me come on to the third point, development of BCR-ABL kinase domain mutations. And this is looking at nilotinib and imatinib. And as you can see, the number of kinase domain mutations are definitely higher with imatinib. Now, looking at quality of life, we all know that each of these TKIs have different side effects, and we need to look at those to actually choose our patients, which Dr. Tulika also told in her talk. And this is looking at nilotinib and imatinib and the side effects. And as you can see, for most of the side effects, it is much higher with nilotinib. And this is one data from the comparison of adherence to imatinib use. And as you can see that with longer period of use of imatinib, the adherence decreases. And this adherence is important because that ultimately leads to the molecular responses one can have in your patient. These are the other side effects of nilotinib, and this is for dasatinib. Most of these side effects are easily handleable, and it seems that it can be used as compared to the advantages that we have. So let me come on to the third point of treatment-free remission, sustained CMR. And this is again data including the before study, all showing you that the toxicities of these drugs are definitely comparable to imatinib. So this is data from STEAM study. I'm sure all of you are very familiar. And again, telling you that those patients who had lower so-called score or those who had better responses with imatinib are the ones who can go off imatinib and stay without the drug for a long time. So this is summary of the various drugs that are there. Again, all of them showing you that there is concept of this stopping therapy, and it can be translated into your patients. It is true with the second generation TKIs also. And so with all this data, I've actually convincingly told you that all these 5 points can be achieved effectively when you use second generation TKIs in the first line. Now, my learned opponent is going to tell me that the duration of these studies is very short. I agree for bosutinib is less, but for Ernest and Decision, you have 6 and 5 years data. And how long do you need further? And again, with longer time, we will see this. And this happened even with imatinib earlier on. We had to wait for almost 8 years to show that there was a survival advantage. And then he's going to tell us about dose escalation with imatinib, and you can achieve the same. But these dose escalation studies have really not helped our patients, as shown here. There was no improvement in over half the patients. And this is from the RENICE study, again showing you that MMR was not seen with higher doses as we thought would happen. So the second point, that all these drugs are more toxic than imatinib, I think these are not supported by scientific data. And I showed you, including the bosatinib, that these are comparable in side effects and discontinuation rates are very similar. And the toxicities are well characterized today because of the follow-up that we have. They can be easily anticipated and many times prevented. And the third point I'm sure he's going to raise is that they're expensive, yes, but if you continue them for a long time, and with this concept of treatment-free remission, if you achieve a good, deep molecular response much earlier, as is seen with the second generation TKIs, you can stop them much earlier, and therefore the costs will be definitely lesser. And of course, we are having generics, so the cost may not be really issue in India as well, because we're talking about Indian patients here. Again, data for you, showing you that nilotinib in the first line, yes, this is expert reviews. One of the second TKIs chronic myeloid leukemia. This is meta-analysis. This is one of the most ones that I got from Jose Cortez. And